I want to thank you all for joining the MHCC Patient Reported Outcome Measures Roundtable. Most of you know me, but I am Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, and I'm joined by my colleagues David Sharp and Anena Onyabo. In the event this meeting is breached, please hang up immediately. Anena will send the participants an email with a new meeting link that will allow you to log back in. The recording will be available to the public. Please contact Kelly Scott or send a chat message if you are having technical issues. You should have received an email earlier today with her contact information. I'm now going to ask the participants to do a brief introduction that includes a few sentences describing the extent their organization is currently using PRO measures. And Zach, I think I'll just start with you.
Sure, absolutely. Good afternoon, everyone. My name is Zach Grabowski. I'm the Director of Practice Transformation at CareFirst. At the moment, we have an interest in patient-reported outcomes measures. I think we are starting to use some specifically around patient experience, but as we look to grow some of our specialty-related programs and our ACO models, having the opportunity to incorporate patient-reported outcomes would allow us to better align incentive payments with performance. And that's something that I think we're certainly interested in. I think there are a lot of challenges still in perfecting them that we want to work out and make sure we're well aware of before we put them into a program. And hopefully we'll talk about some of those today, but it is certainly in our future and something we're planning for.
Well, great, and that's great to hear. And really this is kind of we know they're out there, and how could we use them, and what are the operational difficulties associated with them, but what are the clinical value of using them? So it's good to hear that you guys are considering it. Dr. Scholey, who will announce herself at the end of the call, has extensive experience with implementing these in practices and organizations, and she can provide us with some of the guidelines. But as we go through this, we'll talk about the whole intent of this is to come up with some ways that we can support people who are looking to implement that, whether it's workflow designs, whether it's some kind of learning opportunities. But we'll talk a little bit more about that as we go through. Dr. Modermast, would you like to introduce yourself? I think you're on mute.
You would think after 2 years, right? So good afternoon, everyone. Robin Modermast from Greater Baltimore Medical Center, currently functioning as the Chief of Staff and Medical Director of Care Transformation. We do use some patient-reported outcomes. Depression, I see, is listed as an example, is one that we've been using for a long time. So we do a lot with the depression screening. And honestly, I'm not sure of what some of the other ones might be, but we are very interested in moving forward with anything that's related to population health and delivering better outcomes for our patients.
That's great. We thought that maybe a lot of people might be using that depression measure, but Dr. Scholey will talk about some of the other ones that are available. There is a pretty wide range, but a lot of it's about kind of the collection method as well, and the clinical implications of it. So Adrienne Ellis from CRISP, can you do a quick introduction for us?
Sure. Hi, everyone. Adrienne Ellis from CRISP. I serve as an advisor to CRISP on a lot of different things, but consumer and patient engagement being one of them. For those of you who don't know, although I can't imagine that you don't, CRISP is Maryland State Designated HIE. And so our role here is sharing information between healthcare providers and care coordinators and payers. So we have an interest in patient-recorded outcomes as they may be shared through the HIE. To my knowledge, we don't currently have any specific patient-reported outcomes unless those are maybe documented in clinical notes or something else that a provider might share through the HIE.
Great, thank you. And of course, one of the big reasons is, again, that consumer patient engagement. And, we do view CRISP as a critical partner in our public health and our population health efforts. So we want to be sure that they're involved in these conversations. So I want to thank everyone for those responses. Since there are a good number of people in the meeting, we'd like to sequence the speakers when possible. So if you could signal the team that you'd like to speak by pressing the raise hand button, which is in the reactions menu at the bottom, and then announce yourself when called upon by the facilitator to speak. You can also use the chat function to send messages to specific attendees or all attendees. Additionally, the facilitator may call on people to speak to ensure we have a wide range of perspectives. You can unmute yourself using the small button at the bottom of your screen. If there is feedback coming from you when you're not speaking, staff may mute you. So now I want to talk a little bit about the meeting format and objectives. So we do plan to convene this roundtable monthly beginning in April and continuing through July. All the meetings will be recorded and open to the public, and they'll be held virtually. The notice of the meetings, the time and teleconference will be given through calendar invite or email, and then the public notice will be posted to the MHCC website. So I want to talk a little bit about the objectives, because it's more than just having a conversation about them, although some of it is trying to get out there, you know, what are some of the basics of it? What are some of the possibilities? What are the clinical implications? So we want to convene this patient-reported outcome measure practice roundtable with advanced care delivery representatives to identify challenges and opportunities for practices seeking to implement them in care delivery. The roundtable discussions will inform the development of PRO measure resources for practices, such as information briefs or learning symposiums. The Maryland Healthcare Commission aims to increase the awareness of PRO measures and facilitate implementation in ambulatory practices in Maryland through the development of practice resources that are informed by roundtable feedback. So I provided a document that had some background information on patient-reported outcome measures. I'm not going to read through that, but you know, obviously you're welcome to do that at your convenience. Dr. Scholey will be providing some additional background information that includes the difference between patient-reported outcomes, patient-reported outcome measures, and patient-reported outcome performance measurement. She's going to be also facilitating the discussion. So at this time, I'm going to turn the meeting over to her, and thank you again.
Thanks so much. Can everybody hear me okay? Great. Well, I'm Sarah Hudson Scholey. I'm a vice president at the National Committee for Quality Assurance. I lead our research and analysis portfolio, and I've done a number of projects using patient-reported outcome tools in various forms for research, and also to design tools for accountability purposes. If we go to the next slide. So I guess this is the summary of what I have learned over about 15 years of work in this field. Today we're going to talk mostly about the tools and the measures, but I think in these roundtables we're going to get into all of these issues. But just to give you where I stand, first of all, the reason we use patient-reported outcomes is because we want to focus on what matters to individuals and families, and also to the care team. So it's really important that we think about the effort that we're putting into the process of gathering information directly from individuals about their experiences, their symptoms, their challenges, and then how the care team can use that information in the moment at the same time that we can use it for other purposes. In order to do this, we need to build everybody's knowledge and confidence. I've done research where we talked with patients. They're like, they ask me all these questions and never do anything with the data. So everyone needs to know how how's that information going to be used, and people need to have confidence that they really know what to do with the information. We need to make it easy. That means these electronic, we've got a vast array of electronic tools available to us. I think one of the questions is how do we make it easy and workflow on everyone involved? And our experience is that if it's not part of a shared view of accountability and payment, that this, multifaceted change in how we approach healthcare is going to run into some big challenges. So we'll talk about some of those challenges, I think, in some of the later sessions. But today, just wanted to level set on what does it mean? And we'll go to the next slide. So this table comes from a report by the National Quality Forum, which endorses measures for national use. And I think it's really helpful that we distinguish between patient-reported outcomes, the measures or tools we use to measure an outcome, and the performance measure that might look at whether healthcare organizations are and allow us to compare how well organizations are helping people to achieve an outcome. So here is a specific example of that. So if we think about the area of depression, then depression symptoms are an outcome. So that would be a sleeplessness or feeling sad or depressed, feeling like having no energy. That is the patient-reported outcome. It's what gets measured. The way that we measure it is a tool, and the PHQ-9, the Patient Health Questionnaire 9, that's a 9-symptom checklist that's aligned with the criteria for diagnosing depression. It's a standardized tool that's been demonstrated to be reliable and valid and predictive of a diagnosis. And so this tool, the PHQ-9, is commonly used across the country, and it's not the only one. There are many, many other tools that can measure depression symptoms, but this one is one that was actually developed for primary care and is in pretty broad use. So that's a PROM. But if we want to talk about performance on managing individuals' depression symptoms, then we're talking about a performance measure. And there we have to specify what's the denominator, who are the people that we're interested in, and how would we say that they've improved in their depression symptoms. And that's where we get to a pro-PM. And so this measure, there is a measure that's NQF endorsed. There's a version of it that is in reporting by health plans in the HEDIS set that looks at the percentage of patients with a diagnosis of a major depression or dysthymia and an initial score on the PHQ greater than 9. So that's the denominator. It's people who have depression or dysthymia, and they've symptoms. They have symptoms, evidence that their depression symptoms need to be decreased. The numerator is what percentage of those people have a score under 5 at 6 months, and actually NCQA's measure is actually between 4 and, it's a longitudinal measure saying of all the people whose depression was symptomatic, how many had remission of those symptoms? That's what a score under 5 is at 6 months or at some later date. So that's how we go from the outcome to the way that we measure the outcome to the way that we construct a performance measure for a healthcare organization. So I'm going to stop there, see if there are any questions. Some of you, I think, Robin, you said that you've been using the PHQ-9. Are you tracking this performance measure as well?
We have tracked this in the past, but we don't currently track that specific measure. We do track follow-up PHQ-9s to see how much improvement we've had, but we've gotten away from doing it at 6 months.
So can I, Robin, a question? Why the move away from 6 months? Is it that you think it's not sufficient time, or are you actually looking at it in shorter periods?
I really can't even remember the answer because we've been doing this now for almost 10 years. I think it's been a long time that we've been playing around with depression and anxiety. screening tools. So I think 6 months is a good time. I remember having these conversations thinking about, well, when should we remeasure? What's fair? So I can't give you a concrete answer on that, but I think that 6 months is a good amount of time to reevaluate and see what the scores are. But I like this because, again, going back to even if we take diabetes, so we're measuring the percent of patients that have greater than 9 or less than 8 or whatever it is, but then you lose the ability to actually focus on those that you've helped and how you performed. So you continue to compare your population, but you can have new people that kind of filter in. And if you're a growing practice, it's much more difficult to maintain a good number because you're having people that have come in that aren't well managed. So thinking about those people that you've had the ability to touch and manage, how did you do with them? I think that's a nice way of thinking about it.
So you're saying because the list is dynamic and not static, that it could skew the practice results and actually the perception and approach of a practice, because they may be chasing a number that's never static, and which is skewed to some extent by the patient population mix coming in. Is there a way to control for that?
And I guess you could look at patients that have been within a practice in a certain amount of time. That gives the practice the opportunity to start working with those patients and level set it that way.
Good. So yeah, and actually this question of who's in the denominator, how much improvement do you expect to see over a period of time, and what is that period of time that you use? There's a lot of debates. When we were developing the measure for HEDIS, we heard lots of ideas about this, and actually the remission rate, that getting to a remission of depression symptoms, a PHQ score less than 5 is actually pretty challenging. And so we NCQA pairs this with a measure that looks at response. So did you actually improve by 50%? That's a typical improvement that's used in randomized trials of psychiatric interventions. Others have also looked at just improvement, a certain amount, a number of percentage points of improvement. But like you said, Robin, it really is trying to say, okay, of people that have elevated symptoms, how many are getting better? And so I think that's what's appealing about this measure. And it provides, in depression and other behavioral health conditions, you don't have the laboratory test to be able to say, is somebody getting better? And so using the symptom report from the individual actually helps you to understand, how is that person doing? We'll go on to the next slide then. So we can use patient-reported outcomes in a number of different areas. And I chose a few of these to give you a sense of the variety of constructs and tools that are available. I looked at these first by going to the National Quality Forum to see what performance measures have been endorsed. And I also looked at the CMS measures inventory to see what performance measures CMS is using in its various programs for looking at how organizations are doing on achieving patient-reported outcome improvement or maintaining performance. And so I think probably it's very common to use care experiences tools to measure, to look at access to care. But there's some other ways that people are thinking about understanding people's experiences or their relationship to their care system. So there's a tool for patient activation. There's a new tool that was developed for primary care that looks at person-centeredness of care. And so those are all ways to try to understand the individual's relationship to their care and their experience of care, their involvement in their care and their self-efficacy. But then in the second row, I pulled out several tools that are used or recommended for use to understand symptoms related to physical functioning or symptoms or functioning. So physical functioning, pain, social participation. So those are, what's actually happening to the person in their, to what extent is their health interfering with their life. If we go to the next slide, I've actually given you some examples of the items that are in these different tools, just to kind of show you the variety of tools that are out there. And this is important because as you're thinking about patient-reported outcomes and the kinds of populations you're interested in and the constructs, you may want to think about, well, which of these is really going to help me to understand how well my patients are doing and what I can do to help them achieve a healthier life. So the CAPS tool is used, and I think I was looking at this with some colleagues today. I think there's probably 15 or more different programs in which CMS uses some version of a CAPS tool. Are you using CAPS tools in your institution? I think pretty much all health plans and provider organizations are familiar with those tools. The patient activation module is a tool that's used, it's actually being used today in a CMMI, from the CMS Innovation Center in one of their models for kidney disease. And this is a measure that is really about self-efficacy. So it's about someone's understanding about their health care and their confidence. How confident do you feel that you know what to do with your health care? So that's interesting. There is a performance measure based on this tool. Now, it's interesting. This tool is one that is not like the CAPS is freely available, right? It's maintained by CMS or by AHRQ. The patient activation module is privately owned, and so there's a fee to use the tool. So sometimes that can be a barrier to use, but it does have a lot of evidence behind it, actually really a tremendous amount of evidence also about what to do. The evidence for patient activation is that if you can help, there are evidence-based ways to improve people's self-efficacy in managing their health and healthcare. And if you do that, there's good evidence that improves their outcomes. The third measure that I think of as getting at person's its relationship with their care is this person-centered primary care measure. It's developed by Rebecca Etz from Virginia Commonwealth and the Graham Center. And this was designed for primary care. And it's really more about the relationship of the individual with their care. It's similar to their tools in the behavioral health world that are about therapeutic alliance. That get at how you're related to the healthcare system, and Barbara Starfield, who was my teacher at Hopkins, talked about the importance of primary care, and this tool really tries to get at all those different aspects of primary care. The doctor knows me as a person, stands up for me, coordinates care. I think it's got about a dozen items. So in addition to those, there are a number of items, a number of tools that look at at functioning. So the VR12 is a tool that looks at health limitations related to physical health. Does your health limit you in climbing flights of stairs? That tool is used in some federal programs. The PEG is a tool that the CDC recommends for chronic pain. Again, looking at how pain has interfered with life, enjoyment, and activities. And then the PROMIS, patient-reported outcomes measurement system, I think is what it stands for. But PROMIS is a set of tools. This one I pulled out is about social participation, and it's related to kind of limitations of health on social activities. There are actually dozens of PROMIS tools that get at depression, anxiety, physical functioning, self-efficacy, social participation. They're all free. There are computerized adaptive versions of them that you can use that actually really limit the burden on individuals because it chooses the best items. And so there are a number of ways. So one of the things that I think in thinking about patient-reported outcomes is to understand really what's the logic model you're trying to do. What is your healthcare, your care team really trying to get to an outcome for a population? And some of these work better across a broad population, and some are really more important and targeted to specific populations. We go to the next slide. So I wanted to give you an example of what the performance measures look like. And I mentioned a little bit about how these tools are used in different programs. Like CAPS, like I said, CAPS tools are used in a number of different programs. And the CAPS survey includes a number of different measures, some care coordination, access to care, communication. So there's a whole variety of measures that are part of the CAPS surveys. Depression symptoms, we talked about that. And I mentioned the patient activation measure and how that's used in the kidney care choices model. The VR12, which is looking at physical health, there's also a similar measure that looks at mental health functioning. Those are used in the Medicare Advantage program. They're part of the Medicare Stars. And then in terms of functioning, and I think Zach, you mentioned specialty related programs, right? So there's been some interest in designing functional outcome measures for particular patient groups or conditions. And so the functional status after primary knee replacement, right, is an example of a measure that's in the MIPS program. And that one actually looks at whether people have improved after a knee replacement. So you're starting with a population of people that are eligible for knee replacement. So this measure is collected before the surgery, and then I think it's 6 months after the surgery to see whether people have actually improved. So I want to stop there and say, as you're thinking about this, so does this give you new information? Are you aware of these measures?
So from the Care First perspective, I can say much like any other organization, we are using CAPS as not just a process, but also scoring the outcome and using it to measure against the benchmark. So we'd like to see improvement over time and in comparison to other groups. So that's one that I think we're probably most comfortable with. The PHQ-9 is something we incentivize, but we incentivize the process, not the outcome. So we have a little bit more work to do in order for us to kind of build some of those benchmarks and determine, how we can incentivize performance in that one in particular. And then I will also note the patient activation model is something that our care coordinators do use, and that this is more of a used for the personal relationship of care management, not necessarily as a measure that we would use to determine performance from a provider group or a health system. It's more for our care managers to be able to determine, have they improved on their goal of getting the patient more active in their own care and improve in the understanding of their own care so they can treat themselves post discharge from the care plan itself.
Thanks. Can I just follow up a little bit on that? So on the PAM, so it's through care managers. So if you think about people that are involved with care managers, those would be people with complex needs or potentially post-hospital or something like that. But you haven't considered that for really a care, to guide the care team in general in the clinical setting.
So the way that we use it, so we are providing care, I guess, contracted care managers to support providers that are participating in our PCMH program. So this is something that they would do with the patient and potentially inform the provider about as well. It's not necessarily something that we would use to measure performance of a practice or provider in a value-based program itself. So slight difference there. I think in order for us to do that, we would have to be able to set benchmarks on what we think is appropriate improvement over time and provide resources for the providers or the practices to actually improve on the scores of the PAM survey. So right now we're just tracking it, and I think internally we're probably looking at how the care managers are doing with the PAM scores. I don't know specifically those outcomes. If that does get reviewed often, it's something I can look into. But I know just from a high level it is being used.
Robin.
So I think now that you've had me thinking about this depression remission and response, I believe that was an early ACO measure and that we had used that because we were an ACO. And the reason why we stopped doing it was because it was no longer an ACO measure that we needed to measure. And we really had to narrow down what we were looking at. I mean, I think at one point there were more than 19, and that's just too much to manage. But going back to the other tools, a couple that I just think have really interesting clinical implications are the physical functioning. So I think about, patients that come in and they say, my knee hurts. And so you can address and you can be assured in your own thinking that, well, they're probably not moving around as much because their knee hurts. But if we don't ask those questions about improving or maintaining physical health, then you really don't know. I mean, you walk into a room with a patient and they're usually seated in a chair, and you often don't have the opportunity to really see them move around, and you don't know how their functioning is. And so we do ask questions about, well, have you fallen in the last year? How many times have you fallen? What's your pain score? We ask those questions, but I really don't think that it allows us to have a full understanding of what is going on with a patient day in and day out. So before they fell, if we knew that they weren't getting around or having a hard time with steps, and they didn't bring that to our attention, if we ask a question like this, that would be something that we could intervene with that would probably, help them so they didn't fall and probably have a little more joy in their life as well. Because I think sometimes they probably don't even realize it, or they're ashamed and they don't want to talk about it. They're scared. So I really like that question. The other one I really like is about the functioning, because I think it really helps. We talk about cost a lot and outcomes, but to really know who is providing a service, which includes, the original seeing the patient, deciding if they need surgery, then doing the procedure, then the follow-up to see how they're doing. Usually at 6 weeks or so, they're kind of lost out there. And who really is doing procedures that really are allowing patients to improve in their overall functioning? I think that is really a neat score and would help the public in deciding on where they want to receive their care.
So I'm sorry. I have a couple of general questions. The first is, how are you recording it? And then how do the payers collect it? Because I can imagine different ways that different EHRs would obtain this information. and different needs that a carrier might have around collecting it, those that they're interested in monitoring. So is there a standardized process that you all use, or and Zach, and Robin, I'd be curious to know how that works.
How it works, we aren't doing the things that I just mentioned. So you would have to build a report and then build a workflow in and make sure they have the right discrete boxes that could be checked so that your report is adequate. But currently,
is this something the EHR vendors try to promote and try to help you with if you were to try to take this on, or is this more of a standalone functionality that you would have to, as an organization, you'd have to be on your own to try to solve for?
My guess, and I'll let Dr. Scholey tell me what she thinks, but every time we want to do anything new, we have to present it as a proposal to our Epic team. And then they tell us how many hours and what the cost is. And then we need to decide if we want to move forward with that. And if the Epic team can't do it, then we have another reporting team that potentially can take things off, pulling it out of the EMR and manipulating it in a different way using like BI Launchpad. So all of the things, anytime you ask for something new or a new report, it's something that usually has to be built, and then they assign the amount of hours and the cost.
So it could be a cost factor as a deterrent for using something like patient-reported outcome measures.
It's absolutely new workflows, and working with your electronic health record, or to create tools to document the results, and then thinking about who's going to ask the questions. All of these tools were designed for people to fill them out on their own, and by themselves. So they're not really intended to be a question that somebody asked. But in clinical care, like with the PHQ, that's typically, it's either given as a survey that then gets put into the electronic health record. I'm pretty sure Epic does support many patient-reported outcome measures, so that can EHR systems can support it. You have to think about, well, who's going to actually do the data collection? And I think in the next session, I can show you some of the different ways that we've seen it done. If you have a portal, and if people are using the portal, you can use that and ask people to fill it out before. Sometimes people use vendors to try to collect information before the visit. Sometimes it's part of the workflow. Then an MA would either hand out the survey and enter the data, or ask people the questions. But so really that is part of the question. And then it's also, how does that information get stored in a way that you can actually pull it out and use it, right? Because the PHQ-9 has a scoring system, right? So what you want to know is, for a clinician, the clinician needs to know, well, how do I score, and where does this put someone, and how does it compare to the last time I saw it, right? So you want your electronic system not just to tell you, document the results. You want it to actually provide feedback to the clinician on what this means, and is this getting better or worse, or what to do, right? So some decision support. So all of those pieces of work need to be considered as you select the tool and think about how it can be used. Some of these, sometimes this is done through surveys, like in the Medicare Advantage program, where they use the VR12. That's a survey that's actually completely separated from the care process, and that becomes challenging, because then it's really designed for accountability. And I think health plans that are trying to work on that performance measure actually have to field the surveys themselves and try to think about, well, how do I get the information? Because they're not receiving the direct information that's actually being used to score them in the program. So the issue is if you want to use these tools in a way that's going to guide the care process, then you have to think about the process of, how do you put it into the clinical process and help everybody who's along that chain of data collection and use understand the purpose and what they're going to do with the data. I know Adrienne's had her hand up, and so I want to give her a chance to speak.
Sure, thanks. So taking my crisp hat off for a second and speaking from a consumer perspective, a couple of comments. I know that Epic can do some of these measures because I actually happen to have the luxury of getting, I think it's probably the VR12 and some combination with the pain. I'm actually in physical therapy right now, and every time I go, I have to answer a survey and my insurer is UPMC. And so UPMC uses Epic. Every time I go, I talk about what I can do. Can I climb the stairs? What's my pain? Can I socialize? All of these things. And so it's a pretty seamless process. I can either do it on my portal before I go, or they hand me a tablet when I walk into the physical therapist's office. And to your point, Sarah, they actually do review it. Like as I'm doing my warm up, they're standing there talking to me and saying, I see your pain is a little less, or your pain is a little more. And so I do feel like from a consumer perspective, that actually feels meaningful, because I think one of the points that you made early on in the introduction I think is really important from a consumer perspective, which is you asked me for all of this data, and then how are you actually using it, right? So the idea of I'm answering these surveys, I'm giving you all this information, I'm doing it every week. And I think if my physical therapist wasn't actually talking to me about it, it would feel a little bit more kind of pointless. So I do think that's really important, that if you are going to implement these, you do actually need to have them as a part of the clinical workflow. But I did have a question about, it's clear that they're meant to be done independently without, the clinician helping you answer the questions. But I do kind of wonder, as I sit there sometimes and answer them, I'm like, oh, was my pain really a 5 last week and now it's a 4 this week? And like, what, how do other people answer these questions? And so I'm just curious, kind of, is there any kind of guidance available about like, what if patients are asking questions about how do I actually respond to these questions? Or am I being compared to other consumers, or am I just being compared to myself? So that was the question I had.
Adrienne, those are great questions. So, the guidance for using these tools is actually just repeat the question and tell me what your best answer is. And what we found when we did this, our MAs were really the MAs in the clinical system where we were doing the work. They're like, oh, we want to help people, right? And so it was hard for the clinical staff to say, no, it's your best answer. It's whatever you think. That's what it's intended to be. But that can be hard. It's really hard if people don't understand the words, like that pain question. How much does the pain interfere with your enjoyment of life? And if somebody says, what does that mean, right? The best, from a research point of view, the best guidance would be to say, just tell me what you think, right? We actually, I think, tried to create some additional wording and additional instructions for people, but it really is intended to do that. It can be very challenging if you have people that don't speak English who have another language. Most of the tools are available in many languages, but even when the translation of the PEG was actually, we talked with the medical assistants who spoke Spanish, and they said, people don't understand these words, even though it was in Spanish, they still didn't understand it. So you have to think not just about the language, you need to think about the level of education. So that can be a challenge as well. and how do you help people with it? So that is an issue to think about, particularly if you have limited English proficiency or limited education and health literacy, where you might want to have specific instructions that will allow you to make sure that as you're doing this, you get the same instructions. People are using the same instructions over and over again with the patients. That's going to allow for more comparability over time for an individual, but also across a panel of patients. And I think these measures really are intended to help you understand an individual's experience over time, as well as to understand a panel of patients over time, right? So all of these tools have benchmarks and norms across the country. That's why they can be in a performance measure. If they don't have that information, then they don't really work very well. It would not be a good performance measure. This is one of the requirements for a performance measure is that the tools actually reliable, valid, standardized, and there are benchmarks that you can use where you can say, this is what a meaningful improvement would be on this measure. So they can be used to look at a panel of patients or a population of patients over time and be able to say, well, here's an organization that's doing, is helping to get, depression patients with elevated PHQs to remission. This is 20% here and 25% there. What's the difference, right? So it is intended for that sort of comparison. I hope I answered your questions. Zach, did you have a comment?
Yeah. So I mean, just before I make my comment, just to emphasize the health literacy and cultural competency issues and resources that would need to be available. I mean, I just want to put a exclamation point on that because that is so important in this area. But when I think about these measures, and I think there's two ways to think about them. If your intention is to keep this within a system and within a practice, within a health system, then the challenges that we've listed are certainly correct, right? A provider or a practice or health system could do these scores individually or at their population level. And yes, there are challenges with their EHR that they'd have to work through and new workflows for data collection. But it would be a useful tool once those are resolved. However, if you're thinking about using these more externally and submitting them for a larger reporting purpose, whether it's for contracting or a value-based arrangement with a payer, with multiple payers, we have to think about another challenge, which is new technologies. Right now, an EHR doesn't do the trick. Even if you're able to collect it, you have to be able to submit that data, and it has to be standard across organizations. We've got hundreds of EHRs across the country. Even in this area, I can think of 25 large EHRs that are being used, and there are different. They use different technologies. They use different platforms, and for example, Care First has a tool that we're using to help collect the data and standardize it and pull it from the EHRs, specifically outcomes related data. But it's a challenge even for that company to work with the different EHR vendors, and it adds additional costs that then they pass on to the providers. Sometimes it works, sometimes it doesn't. So until we're in a position where we have those types of technologies and the EHR companies are willing to work with these vendors or these companies to do so, and whether that pressure is put on by the payer or the pressure is put on by the purchaser of the EHR saying, hey, we'll purchase eClinicalWorks or Epic if you agree to work with this company to help submit our data to the payer. That's a challenge that we have to overcome in order for this to actually be meaningful outside of the system.
That's exactly what we've heard on the depression measures for HEDIS. We did some work with some health plans on trying to improve reporting of those measures. It's just really hard. Not only do you have the workflow issues, but then you have the issues of how does the data get transferred to the health plan. And so it's everything you said, Zach. Robin.
just to go back and underscore something I had said earlier, which is about the amount of things that we're measuring. So the great news is that we do have these wonderful EMRs, and they are able to do some reporting out of them, which is terrific. But the reality is that there are only so many minutes in a day. And so there's only so many conversations around the data that you collect that you can have. And so prioritizing what we're asking and why we're asking it is really important. And that can change. Maybe this year it's something and next year it's something else. But we just can't do it all the time. And that's one of the things I've learned in my career during population health is, really have a few specific areas you're going to focus on, and then you can get some wins. When you spread yourself too thin, you just can't do it. And it's annoying for patients. So we collect currently social determinants of health because we had to for our Maryland primary care program. But we don't really do much of anything with that. And I think that's so frustrating for the patients. They've taken the time to answer the questions, they've given us information, and maybe we do something about it when it pops up on the screen. But the biggest thing is collecting a lot of this information doesn't pop up on your screen. So we'll send out information to the patients ahead of time and ask them to complete it. And then it's not obvious to you as a clinician when they come in. You have to kind of go looking for that. And that's problematic. So I know we're just, learning our way through EMRs and they're developing, but like with PHQs, we have to go pull that into our notes or go look for it on the flow sheet. And then if you pull it in, you can see it over time and give you some answers about how people are trending. But there's still some nuances, and you just can't go looking for a bunch of things in different places and then try to address the real reason why the patient came in.
Absolutely. I think this is why it's very appealing to, and I think we all believe, and I don't know if CMS in their national quality strategy said, patient outcomes, that's where we're headed. But I think we have to be really intentional about focusing on what matters and really thinking about the population, what's most important to ask for a specific population, where you're going to be able to do something about it, and help people, improve in some aspect of care. Because as you said, there's so many specific technical and workflow issues and a cost associated with those. And there's also the time factor and the burden of the information, right? The worst thing of all is to collect information and then just not use it. So completely agree with the issues that you've raised here.
Can I just say one more thing that has also come up? When does this visit change from the patient's visit to the provider's visit? So now I'm collecting information. I have my own reasons for wanting to do something during a patient visit. And a patient presents and they have a totally different agenda. So how do we merge those two agendas so that the patient is getting what they need and the physician also gets what they need? That's one of the things we've juggled and struggled with over the years.
And in the next session, maybe I'll tell you a little bit about an approach that we're using that's we call person-driven outcomes. That is about trying to elicit from individuals what matters to them. So it is using patient-reported data, but in a little bit different way. So if Melanie agrees, then I could bring some of that information, because I think it is addressing the issue that you've raised about trying to merge those agendas. I love the way you framed that.
So thank you so much, Dr. Scholle, and thank you to our participants for some really great conversation and feedback and your perspectives on this issue. As we've discussed, this is still emerging and people are starting to implement it, but obviously there's a lot of challenges. What could we be doing? How could we be doing it? What's the best support? So the goal of this roundtable is to bring some of those out and to talk about what could we do to help support some practices or systems that may be interested, such as doing like a learning session, maybe doing some basic workflows to share with people, or helping to do maybe like an information brief or something like that. So David, I don't know if you want to build on what I was saying, but that's what these meetings will be used for, is to develop some practice resources.
Yeah, no, I think this was an excellent conversation, very enlightening. The 60 minutes just flew by. And it's really informative because it leads us to some place, and where it leads us to is a bit of an unknown, and it creates curiosity. But you guys are the smart minds that will really help us create a pathway for lots of folks to follow. So thank you for your time. Really appreciate it.